Hi, everybody. It's Dr. Tawari.
It's Dr. Kochak. How's everyone doing?
Well, we thought we'd do a little update on what's going on with coronavirus and breast reconstructive surgery. There's a lot of confusion out there, understandably, for patients. And what we've tried to do over the last couple days is get an understanding of what not only the Plastic Surgery Society is recommending, but also what our colleagues in the breast cancer surgery world are recommending for patients who um, are patients with active cancer who we're exploring reconstructive options for.
Really, it's, because right now we're getting so many questions and queries about when we might start doing surgeries again and why we've stopped doing certain ones. And we're just really responding right now to the recommendations that are coming down from many different levels. At the state level, we've had recommendations, but we're also very lucky that our society is not just the Plastic Surgery Society, but the American Society of Breast Surgeons as well, have all laid out some guidelines and some recommendations about which surgeries would be considered more urgent and which ones should be delayed until this pandemic starts to calm down a little bit.
Yeah, I think all hospital systems across the country are worried about uh, the personnel, the nurses, the physicians, the respiratory techs, all the folks in the hospital that are such critical frontline people right now. They're worried about the personal protective equipment, and they're also worried about exposure to patients unnecessarily, putting patients at risk. So I think all those variables are what they've considered in coming up with these guidelines. So Dr. Kochak and I thought we'd just kind of go through guidelines with everybody so people have an understanding what's been going on here. So let me see if I can
Yeah,
bring
so
this
for those
up.
of you who are watching this on our video YouTube channel, you'll be able to see this screen share. But if you're listening to us on our podcast, we'll be able to talk through the things that we're seeing on the screen pretty clearly. So nothing to worry about. But this will be at least to have a visual aid if you're watching us on YouTube, and if you're listening to the podcast, feel free to find us on YouTube so you can see these documents specifically.
So hopefully we have this table up right now. This is the executive summary from the American Society of Breast Surgeons. So these are the breast surgeons who do the breast cancer operations. And this is their recommendation during the COVID-19 pandemic. And I'm going to fast forward here to table one, where they've really kind of established what they call priorities A, B, and C. And Dr. Kochak's got a pretty good understanding of this, so I'll let him kind of take it from here.
Yeah, so the priority A folks are really emergencies, things that have to be handled emergently, can't sit on at all. And then priority B, they've defined that as cases where the problem that needs to be dealt with has to be dealt with not emergently, but urgently in a 6 to 8 week period of time, basically making it something that has to be dealt with during this peak of the pandemic. And then category C really is the group of operations or cases that they feel can be put off beyond the 8 week point so that they can be done delayed out farther after the pandemic starts to really calm down.
What's relevant for us is this table three, which is the priorities for patients who are going to anticipate surgery focused on surgical oncology. And they really go through in some detail what to do with patients, not only for the cancer part of the operation, but also the reconstructive part of the operation.
Yeah, and you can see here in this sort of category B things that they think can be done at the present time. Really, if you look at what they're recommending that can be done, it really boils down to patients who have an active cancer, and they're really recommending that the treatment be limited to the active cancer side. And they do make a specific statement about the reconstruction. I think Dr. Torrey was outlining it there. You can see that they consider anything that is pertinent to an autologous tissue reconstruction, like a DIEP flap. They're basically outright recommending that anything in that category be completely delayed. And they've put it there in their first column, I think, to very clearly state that that's something that should not be prioritized at this time. But in the middle column, in that, and they do say that reconstructive surgery can be done, but they're asking that it be limited to a tissue expander or an implant reconstruction. And once again, that autologous tissue operations be avoided And they really are encouraging that the operations be limited to the cancer breast, and we'll kind of show you that on the next column. But I think this is an interesting thing because the reason they're recommending that a reconstruction can maybe be done when needed is that these operations, the tissue expander ones and the implant ones, are going to potentially utilize less of the hospital resources. They'll allow for the patient to have their surgery and potentially go home the same, if not the same day or maybe the next morning. And so it'll prevent a bigger burden on the hospital system like an autologous tissue reconstruction might otherwise cause.
I think it's really important to mention here that we use tissue expanders even in the setting of autologous reconstruction. A lot of times we'll do what's called a delayed immediate approach. So what does that mean, delayed immediate? For certain patients, for example, patients that may need radiation treatment or patients who were not clear whether the best approach for them is going to be an implant or autologous tissue, we'll put in a tissue expander at the time of the mastectomy and use that to preserve the overlying skin so that ultimately we can then go on to a DIEP flap or an S-gap type reconstruction. So it's not uncommon for us to use this delayed immediate approach, just like this statement is outlining, where we can place a tissue expander and defer the autologous reconstruction to a later date. And I think this really still preserves the best kind of cosmetic and reconstructive outcomes for the patient.
And one more thing on that sort of note, even though at the time of the surgery right now, we're limiting our surgery to the cancer breast, a lot of patients sometimes are interested in a contralateral prophylactic mastectomy. And they're really clearly saying, and as Dr. Torre is outlining there, they're really clearly saying that we shouldn't be doing those prophylactic mastectomies right now, and they should be deferred. And it's okay. So if we put a tissue expander on one side, and we can always come back, really that tissue expander gives us a window of time that can be as long as up to a year. And it gives us plenty of time to be able to plan and come back and do the rest of the surgeries. The prophylactic surgery could also happen at that same time. And we really would have lost almost nothing in terms of our reconstructive result, because tissue expander on the cancer side would have preserved any skin. We could take that out and replace it either with an implant or one's own tissue, a DIEP flap, and then do the mastectomy reconstruction on the other side as we would have usually. So it actually, it provides a really reasonable algorithm for us to be able to still get people the reconstructions that they would have gotten otherwise.
Yeah, and it's really important to note that this has nothing to do with insurance. It has nothing to do with the Women's Health Care Act of 1998 or, how important these surgeries are. This has everything to do with resource utilization in this very kind of extraordinary time. So those are some of the recommendations for the breast cancer surgery. What about the reconstructive surgery? We're going to flip over to a statement by the American Society of Plastic Surgery, which is a society that Dr. Kojak and I belong to. And this is their resource page for the COVID-19 recommendations.
So to prevent any confusion, the last one we just looked at and talked about were the ones provided by the ASBS, which is the American Society of Breast Surgeons. And this one is the ASPS, which is the American Society of Plastic Surgeons. So they sound very similar, but this is our society. This is the Plastic Surgery Society.
Yeah, exactly. And so the first thing they go through is what to do about delayed reconstructions and revisions. And for a lot of our en-bloc patients, they would fall under this category. So these are people that we're doing a delayed reconstruction on, meaning they've had the mastectomy in the past, or someone that we've done a reconstruction on that we're now doing a revision. And again, the en-bloc patients fall in this category. And what they say is delayed breast reconstruction and planned secondary or revision breast reconstruction are elective and should be postponed until the system in your area can accommodate elective surgery. So in the state of Ohio, our governor has put a hold on any elective surgery because of the resource utilization, the PPE protection, all those things that we've talked about. So that's the consensus statement for delayed reconstructions, revisions, and again, en-blocs fall in that category.
Yeah, and I think it gets a little more complicated when we start to think about the immediate reconstruction category. And I think a simple summary boils back down to if the breast surgeons are doing the mastectomy because it's necessary and it falls sort of under that category B that we talked about before, then it probably opens the door to reasonably do a reconstruction on that breast. And the reconstructions, like we said before, if it's a mastectomy, certainly could be placement of a tissue expander, but we're avoiding autologous tissue reconstructions. But there are probably also other options if a patient's having a lumpectomy as part of breast conserving therapy. And if they're a good candidate for something like a oncoplastic breast reduction at the same time as their lumpectomy, that might actually be something that we could consider doing at the time if it's indicated.
Yeah, so they talk, just like Dr. Kojak said, they talk about oncoplastic surgery as part of their um, algorithm here, and it should be evaluated on a case-by-case basis, depending on the complexity of the reconstruction. So oncoplastic surgery, like Dr. Kojak noted, which is essentially doing a breast reduction type technique at the time of the lumpectomy to lessen the impact of radiation changes on the breast. That type of an oncoplastic reconstruction is something that can be considered. When it comes to the DIEP flap autologous reconstruction, I'm jumping around a little bit here in their recommendations, but they pretty clearly recommend that this should be delayed until we're beyond this pandemic period. In general, they're telling us to err on the side of caution. However, on a case-by-case basis, it's up to the breast surgeon and the plastic surgeon to determine whether an immediate tissue expander or a direct implant reconstruction has a role in the management of the patient. So again, I think the ASPS and the ASBS are consistent in that they recommend tissue expander reconstruction for active cancer patients on a case-by-case basis.
And they even go on here to clearly state that, very similar to the breast surgery society, our group also really clearly says to avoid cancer on the prophylactic side or doing it on the non-cancer sides.
So I think that's a good way to think about these recommendations for at least the short term. Again, we don't know when a lot of this is going to change. You know, I think we're trying to keep up to date here day by day, minute by minute. As soon as we learn something that is going to impact the care of our patients and the understanding of how to proceed, we will be sure to share that. But as of right now, April 1st, 2020, these are kind of the most up-to-date recommendations.
And it's probably safe to say that, if things become worse and the hospital systems become more overwhelmed with the care of patients with COVID, then these recommendations will probably change and become more stringent and probably make it less possible to do even things that they're considering in that sort of middle category right now. So we're taking it on a day-by-day basis, and we're once again referring to the recommendations coming down from the society level, but we're also very, very careful to pay attention to what is being laid down at the state level in terms of what should and should not be done. So we'll do our best to keep everyone up to date, but that's our update for right now. We appreciate you tuning in.
Yeah, if you folks have specific questions, always feel free to email us at info@mwbreast.com, info@mwbreast.com. Until then, keep safe, keep healthy, and we'll hope to talk to you all soon.
Bye-bye.
Bye-bye.
All right, I did it. Hold on one second.